Hello, today we are going to be covering inflammatory disorders. It is chapter 23 of TIMBY MedSurg. First, we're going to talk about infective endocarditis. This is the inflammation of the inner layer of the heart tissue. It is an autoimmune response. So, organisms such as bacteria and strep, staph, fungi, those are the most common. It can also be caused by prolonged IV, insertion of a cardiac pacemaker, cardiac catheterization, Foley's. Just think of anything that can bring an infection into the body. Some assessment findings that you're going to see are fever, chills, muscle aches, joint pain, Osler nodes. Osler nodes are purplish nodes on the hand that are painful. Splinter hemorrhages. Janeway lesions. The Janeway lesions are painless red-purple macular lesions. They can also have Roth spots. These are white spots in the retina surrounded by areas of hemorrhage. Petechia, enlarged spleen, and heart murmurs. This can defect the valves, which the valves can develop vegetations on them, which are fibrous substances growing on the valve. So let's think about if one of those comes off. What's going to happen if we have this fibrous substance going through? Clotting. Obviously, I can't hear your answers, but clotting. This could lead to clots. Here is a question. Which of the following histories of a client would relate to a diagnosis of bacterial endocarditis? Previous heart cath, strep throat 4 weeks earlier, open reduction, internal fixation of the left hip last year, smokes 2 packs of cigarettes a day. The answer is B, strep throat. Remember, common causes are the bacteria, strep, staph. Not saying that an open reduction of last year, probably not the cause. A previous heart catheterization, we don't know when that previous heart cath was. And smoking is not a related factor. Looking at some diagnostic findings, you could have anemia, leukocytosis. You could look at blood cultures. You could look at EKG strips. With our medical and surgical management, we're going to have high doses of IV antibiotics. This could last for 4 to 6 weeks. We also want to provide NSAIDs for fever or inflammation, bed rest, and they can even have valve replacements. Our nursing management, we're going to limit activity, assess for changes, look at their pulse rate and rhythm, and administer those antibiotics. Myocarditis. Myocarditis is the inflammation of the muscle layer of the heart, so the myocardium. This is rare. It can be caused by viral, bacterial, fungal, or a parasitic infection. However, usually it is caused by a virus. The big assessment finding here is you're going to have sharp, stabbing, or squeezing chest discomfort, which resembles an MI. So again, sharp, stabbing, or squeezing chest discomfort. Setting up relieves the pain. They could have a low-grade fever, tachycardia, possible dysrhythmias, dyspnea, cyanotic skin and crackles with S3 nodes. Medical and surgical management, we're going to have them on bed rest. These patients need to be on a sodium-restricted diet. We're going to look at giving them digitalis, They could possibly have to have a heart transplant. We're going to monitor their cardiopulmonary status. We want to monitor vital signs, INOs, daily weights, O2 sats. There are three types of cardiomyopathy. You have dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. With dilated, it is an enlargement and dilation of all the four chambers. This is the most common type. So with dilated, it's an enlargement and dilation of all four chambers. With hypertrophic, the myocardium is enlarged, especially on the left side, to the point that it diminishes the function of your ventricles. Then you have restrictive. This is when the ventricle walls are rigid, which prevents ventricular filling. So your different assessment findings with dilated, you're going to have dyspnea on exertion and when laying flat. Fatigue, you could have leg swelling with palpitations. With hypertrophic, you can have syncope, chest pain. However, these patients may be asymptomatic. You can also have restrictive. With restrictive, you can have dyspnea, and you can have dependent edema in the legs. With restrictive, you're also going to have a low cardiac output. Medical and surgical management, you're going to look at medical. We're going to give diuretics to see if we can get some of that fluid off. Digitalis, antihypertensive, antidysrhythmics, anticoagulants to make sure we're not having any clots. Corticosteroids, and again, with the cardiac, we're going to have a low sodium diet. Surgical, they could need a pacemaker, defibrillator, or even possibly a transplant. Some nursing management. What are we going to do? We're going to look at their medical and family history. Obviously, we're going to do a physical examination, vital signs, lung sounds, heart sounds. We're looking for edema, any kind of abdominal enlargement. So is there any signs that fluid is building up? We're going to monitor their cardiac, O2, and of course we're going to provide emotional support. Pericarditis is the inflammation of the pericardium. So this is the inflammation around the heart. It can be secondary or primary. The biggest thing here is looking at cardiac tamponade. This is an acute compression of the heart. This is a medical emergency because you need to relieve that pressure. Pulsus paradoxus, this refers to the falling of a patient's blood pressure during inspiration that is greater than 10. So it refers to a falling of the patient's blood pressure during inspiration greater than 10. Some assessment findings with pericarditis is you can have a fever, malaise, heaviness in the chest, pericardial pain, moving and breathing worsens the pain. Sitting upright and leaning forward relieves the pain. They can have a friction rub and severe hypotension. A diagnostic finding that we're going to see on here is your ST segment on your EKG is elevated. So your ST segment is elevated. With your medical and surgical management, we're going to provide rest, pain medication, antipyretics, NSAIDs, corticosteroids. Some nursing management, we're going to monitor their pain, auscultate the heart sounds, watching and seeing if we see any JVD, monitoring for a persistent cough, dyspnea, fainting, any signs of anxiety, or any changes in the pulmonary function. So part of the nursing process for pericarditis, we're going to monitor for tachycardia, watching for the pulsus paradoxus, neck vein distension, listening if there's any kind of muffled sounds. If they do have a pericardiocentesis, we're going to cover that site with a sterile dressing and inspect that dressing for bleeding or leaking. We want to evaluate our patient. We want to make sure the pain level is at a level they can tolerate. Vital signs are stable. We're looking for normal cardiac rhythms, and we want to avoid or manage cardiac tamponade. So a patient with pericarditis has been admitted to the cardiac intensive care unit. The nurse caring for the patient knows that the most common clinical assessment of pericarditis is what? Select all that apply. This is going to be E. All of the above can be seen with pericarditis. Thrombophlebitis, we have already talked about this. It's the inflammation of a vein accompanied by a clot. So we're talking about our DVTs, PEs. We're going to look for it's the inner vein is irritated or injured, platelets clumped together, which is forming that clot. The Virchow's triad is your venous stasis, altered blood coagulation, and trauma to the veins. So the triad that we're looking at. Our assessment findings: discomfort in the affected extremity, calf pain that increases with dorsiflexion, which is that Homan sign, heat, they can have redness and swelling, the capillary refill could be less than 2 seconds, fever, malaise, fatigued, and even anorexia. Buerger's disease. This is the inflammation of the blood vessels associated with clot formation and fibrosis of the blood vessel wall. Your assessment findings, they're going to have cold, numbness, burning, and tingling feet. They could have leg cramps after exercise, pain at rest, cyanosis, and redness of the feet and legs. The skin could be mottled with purplish red and appears thin and shiny, sparse hair growth, and they can have black gangrenous areas at the toes and heels. So here's an image of what the feet could possibly look like. Nursing management, we're going to try to help with the pain, examine the extremities and nails, monitor your skin temperature and your peripheral pulses and capillary refill. A nurse is educating the client on the causes of Buerger's disease. Which of the following would indicate a client's understanding of the disease process? The answer would be C. The condition is associated with smoking. Buerger's disease is an inflammatory process affecting primarily the medium-sized arteries or veins of the legs and causes an occlusion of circulation. Smoking, which causes vasoconstriction, can exacerbate the disease process.